And then after which, so if anybody has questions, you can either put it in the chat or you can raise your hand, and we can call you to answer your question. But for now, I want to hand back to Dr. Abe to introduce our speaker because he knows her very well, and I don't want to do injustice by introducing her. So Dr. Abe, I want to hand back to you.
Thank you so much, Amma, for this opportunity to introduce my good friend, Dr. Susan. She doesn't like profile to be read about her. She's a very simple woman. She loves things to flow naturally. But I am of the thought that when people earn, they must be recognized for their work and their effort. And so please permit me to read just a brief bio of Dr. Susan Koduah. Susan has been an oncology nurse for nearly 20 years with different roles throughout these years. With her passion for teaching, she also played a role in precepting both student nurses and new staff nurses for nearly 15 years. She served as a nurse educator for the oncology unit for 3 years, and then she also became a certified holder, certification in adult oncology nursing. Graduating in 2016 with a master's in nursing education as her concentration. She is a very passionate leader who love the work she does. And in just recent year, she successfully graduated with a PhD in nursing. I always take off my hat for anyone who goes through a PhD program. It's another monster on its own. And so to see Susan successfully go through that program, we officially welcome her to the 1% elite class of PhD holders around the world. And so without wasting much time, friends from around, I have this single honor to introduce our guest in the person of Dr. Susan Koduah. Susan, welcome.
All right. Good morning, good afternoon, good evening, wherever you find yourself. It's a pleasure to be with you all. And I suppose everyone can hear me very well, right? If you cannot hear me, please let us know. So we are here to have, I call learning to be fun as a teacher. And just to clarify, actually, my PhD, it's in psychology, so also a psychologist now with a concentration in cognition and instruction, which takes me to the nursing education section. So we all get that. It's a beautiful Saturday, and you all have taken the time to be here for us to learn. Do I know everything about breast cancer? No. Do I have significant knowledge about breast cancer? Yes. And if the moderator will allow me, I like to get my audience engaged. So I personally do not mind. So at any point, you can stop me to ask your question. I do not have a problem with that. If that is okay with our moderator, because I need permission for that, so we can get engaged.
Yes, right? Please. Okay. I think that should be fine.
Okay, good. And I always say I think I was born as a teacher, so I like to get people engaged, and I have the permission, I suppose, to share my screen. I actually like this session because last time we did it on radio. This time you get to see my screen, so you can actually see, because there are different learning styles, and this is an educational session. So I will also have the disclosure of people that sometimes know me later. They might say, Susan, that was deep. So this is my teacher mode. This is not the Susan out there mode. This is my teacher mode, the nurse mode, the whatever you want to put it mode. So allow me to share what I know about breast cancer and whatever you have experienced also. This is learning. I see myself as a facilitator also. So if you have experienced something personally, please share. and we will be more than happy. I will be more than happy to answer your questions for you. At the end, if you think there is something very personal to you, I typically do not mind. I can put my number in the chat. That's my other calling, and you can call me if you choose to do so, because sometimes there are questions that people may have that they do not want to ask with everybody around. So I am open to that. You just have to let me know, or you can contact Dr. Abbey and he can give you my number. If you should take my number, it's best to text me, because if you're not in my contacts, my voicemail will not allow you to leave a message. So just FYI on that. So it's best to text me and I will call you back. So I will start sharing my screen. And everyone see my screen? And we can also hear me okay?
Yes, please.
Okay, great. Just a question for I see people in the room. Am I co-host, so I have all the hosting privileges? Just so I'm not back and forth.
No, you go ahead. We're taking care of them.
Okay, all right, good. All right, so sometimes people ask me, this is, for me, this is informal. Like I said, you see it formal, but I see it informal. Why do you like to talk about cancer so much? It's quite unfortunate. It is something that is it's with us. So we need to hear about it. We need to talk about it. We need to educate ourselves so we can do or find means of preventing the ones that we can prevent. To talk about any kind of cancer, or in this case, we are here this month, it's Breast Cancer Awareness Month. It's Awareness Month for a whole lot of things, but we will stick with our breast cancer. Breast cancer is a collection of diseases, just so everyone is aware. So when it comes to treatment, before I get into all that, it's important to understand, I think, for anything that you do, the anatomy of the breast. So take a good look. Hopefully you can see it well. With that one breast, this is what you have, because there are some that you see as we move along that I'll talk about breast cancer that's involved with the ducts and the fatty tissue. So the ducts, as you see, I'm not good with description. I think it looks like, if you can see where my arrow is pointing, that's the ducts, okay? And then the fatty tissue.
So do you mind making it bigger, maybe F5 or so?
Let's see. Yes, let me make it 100%.
Now, I think if you click on the presentation, the other one, just closer to the where you were before, downstairs, there is like okay, so come a bit left.
Make it less, it's too big?
No,
this is good.
No, after that, there's a good, that one. If you click on it, it will
slide. Okay, you want the slide show.
I think it's better for the viewership.
Okay, great.
Thank you. Appreciate it.
Okay. Okay. So is this better for everyone?
Yes.
Okay. So this is the ducts, because there are breast cancer that gets involved with the ducts. So it's important to know the different parts of the breast. We all know breast, but some of us may not know the different things that goes on in the breast. Fatty tissue, that's just fat. Blood vessel, and when cancer cells starts to grow, they feed into that. So it's important to know the blood vessels that are feeding into your ducts, your fatty tissue. Lymph nodes, some cancers get involved where the lymph nodes get involved. The areola, that is depending on your color, black, brown, whatever, it's around the nipple. That is the areola. And sometimes you may see when breast cancer gets pretty bad, that it actually, the tumor comes out through there, and that's when unfortunately you see it among our kind of people, because we wait too long. or we are in denial. So then you actually see it become a wound and it explodes that way, which is very difficult to watch and very painful. What is cancer, right? We need to understand what is this cancer that we talk about, or we're making so much noise about cancer. It's just any cell that divides rapidly. You cannot stop cancer growth unless something is done about it, which is why we need to talk about this prevention or preventative measures, the way we live, the things we do, so we can stop the growth of cancer cells. Because typically cells are supposed to, they die and the new ones are made up. But when someone has cancer, they just get out of control. And it's quite unfortunate. I guess even the air we breathe, it's my own philosophy. It's even causing cancer now. So much pollution in this world. So it's just a multiple replication and they just do not die. And they keep going on and on, becomes a tissue, a mass, then which is how tumors are formed. When it comes to breast cancer cells, these three hormones that I have here that I'm talking about is very, very important. It's significant in the treatment, in the prognosis, when someone has breast cancer. If you remember before, I said breast cancer is a collection of diseases. So there is estrogen receptors. So you may know somebody, or you may have read or heard that somebody has breast cancer, which is ER negative or ER positive, or is PR negative or PR positive, or is HER2 positive or it's negative. These are very important. You cannot treat someone with breast cancer without knowing these hormone receptors. It's very, very important. So any time somebody tells me they have breast cancer, I ask them, do you know your ER, PR, or HER2 status? Because then I can help that person in terms of, because I have a lot of people that will call me, what do you think of this? This is what my doctor is treating me with. And then I'll ask, do you know your status? And it's sad that, and I'm making this very clear, that if you know somebody who has breast cancer, especially within our community, because we do not ask questions, you will ask somebody, if I've talked to people within our community, you have breast cancer, okay, what is your ER, what is your PR, what is your HER2 status? They don't know. So they don't even understand what and why they are being treated the way they are being treated. So those things are very important. So if you take nothing out of this discussion today, please take home that when someone is diagnosed with breast cancer, it's important that they know their estrogen receptor, progesterone receptor, and HER2 status. It is obviously the most common breast cancer among women. And as the video showed, 1 out of 8 women do get diagnosed with breast cancer, irrespective of race or ethnicity. Most common one for Hispanics, and we live here in America, and other people I know are calling from all over the world. I'm sorry, I do not have the statistics for all across the world, but if you want to know, please contact me. But since most of us are also here, we see a lot of Hispanics, which is why I mentioned that most common cause of death of cancer among white, Black. So I think most of us on here are Blacks. So it is the most common among whites and Blacks and Asian. As you can see, I'm not going to read them. This year, I believe, is 2021. That's the number you see there. And for those of us on here who do epidemiology studies, most of our public health sector staff, they know what that is about. That because somebody asked me that question before, which is why I am kind of talking about it. It's like, why are you talking about the year that we live in and how many people are going to be diagnosed with cancer? And I said, well, this is where we live. They need to know so that they can prepare. In this country and mostly in developed countries, plans are made based on statistics, what we have. So they need to know how many patients are expected to have this kind of cancer. So this is quite a significant number, 281,550. And that's the invasive type. We will talk about the different types. And about 49,000 for the non-invasive, which is the ductal carcinoma in situ. We'll talk about all that, so I'm not expanding on that. Do men get breast cancer? Yes, especially if you have some predisposed or certain things within your family. Yes, men do get breast cancer. So 2006-20, that was last year. I don't know the expectation for this year, but that is still a significant, if you look at it from research point of view, it's a significant amount of number for men, because most of us think, oh, men don't get breast cancer. Yes, men do. It's just predominant among females. 10% of women that were diagnosed in 2010 were below age 40. And we'll probably dive into that, or if you have a question as to why, you can ask me. Below age 40, due to mutation and late diagnosis. Most women around that age are exposed to estrogen. And when we talk about risk factors, we will explore more or expand more on the effects of estrogen and some of the things that we need to do as women, especially in the modern world that we live in. Any question thus far? Okay. Bracha genetic testing, I feel, it's quite, I think last time when I did this, the Bracha website was available, so I could direct people to go check their Bracha status. And Bracha, as you can see, that is the full meaning there. It's one genetic predisposition that some people have that shows that they have a higher chance of getting breast cancer. I always use the celebrity, what's her name? Most of you may know, Angelina Jolie, because she knew she tested positive for Bracha. So she went ahead and did double bilateral mastectomy. And I my hat off to her. I think she did the right thing, because she had both Bracha 1 and Bracha 2. So that was a very high chance for her. It's testing that you can get done. But like I said, they used to have the site. I actually did it myself, where you answered questions and you could tell if you were at risk or not, but they've taken that down. So Bracha is a tumor suppressor. So within our body, if you're not if something is growing in you and it's not being suppressed, that means your Bracha, that genetic susceptibility is off. So then you need to get things checked, and it's inherited from both parents. Let me make this right here. Genetic testing, talking about this can take us another day. So I'll make it very precise. I'm just talking about Bracha, that if anyone tests positive for 1 or 2, they are at risk, and it's inherited from both patients because they are cancer mutation genes. Women with mutations are 7 times higher to get breast cancer and 30 times for ovarian cancer before 70. So if I lied, you see the significance of Bracha, right? And as to why it was important for Angelina Jolie to do a double mastectomy. And while we are at this, I know there are some men on there. It also increases men's risk for prostate cancer, because prostate cancer, as you may know, that is also a hormonal type of cancer. I would not do anything with prostate cancer. That's another whole thing. I'm just mentioning it, that if you are a guy on here and so in that case, actually, a guy whose mother has breast cancer, that also increases that guy's risk of prostate cancer because of this Bracha. I will leave it as that. If you want to know more about prostate cancer, let me know. Any questions about this particular genetic testing? Okay. Am I moving too fast, or we're doing okay?
I think we are doing fantastic. We are enjoying ourselves.
Okay, good. All right, risk factors, genetic mutation, and that's one of them is what we talked about. Family history, 5 to 10%. Obesity goes with everything you can think of. Obesity, alcohol, it goes with anything you can think of. Increased estrogen production. I will tell you, this is my favorite slide of all, because this is where typically I'll have questions or I can probably explain some things for you. Age greater than 60, having children after the age of 35. I will explain all this. And women who do not have children at all. Early menarche, that's for women who menstruate early. That's the menarche before age 12. And these days, and it's unfortunate, and I will say this, that's also why breast cancer is increasing, because children are having their period as young as 9, 10, you know, it is what it is. So start teaching your young girls. Late menopause after 55, birth control use in the last 10 years. African American, less than 45, we talked about that. So the having children after 35, early menarche, late menopause, birth control use, all ties in with the increased production of estrogen. Because the longer one is exposed to estrogen, if you remember, we talked earlier about the hormone receptors for breast cancer, and I mentioned estrogen receptor, progesterone receptor. For an individual or for a woman to ovulate, once you're ovulating, you are making estrogen, it's increased. So we actually want women to hopefully ovulate less, unless, you know, you want to have how many kids, only God knows. Because with less ovulation, obviously, you will not be that pregnant, right? You need to ovulate to be pregnant because you need that. But with less ovulation, less estrogen. You know, we cannot win in this world about a lot of things. That there is one thing that I actually had in my notes here. This also brings me to breastfeeding. Ladies, please share this with your friends, or if you happen to be one of them. Breastfeeding, and I usually have people ask me questions through the back door, so I will just say it on here. Don't ask me that question through the back door. Breastfeeding and your partner, your spouse, breast sucking, because I get that question back door. It is important that that happens, okay? So let's all be clear, we are all adults here, and like I said, this is my teaching mode. When that happens, you make less estrogen. The less estrogen you have, so that is the correlation for those of us on here who do research or get that. Less estrogen, less risk of breast cancer development. Hopefully, I am making this clear. Less estrogen, less risk of breast cancer development. So hence, if you are one of those who say, oh, I don't want to breastfeed because my breast is not going to be in the same shape, forget that. And I usually never mind using myself as an experience to share my story. So I usually talk about me. I breastfed and I was working full time, okay? I breastfed at least, I wish I could have done more, 1 year. And some women use it as birth control also. So the less you do that, the better. I mean, the more breastfeeding, the better. And engage with your partner, they're not going to hurt you. It's actually good for you. Birth control use, there is more studies out there. And in those days, a lot of people were doing, oral contraceptives, where most of the oral contraceptives are made with estrogen. So estrogen is a big problem. And also some women who are postmenopausal and they take some estrogen stuff to help them with hot flashes. So it's just tough that we have to find a balance. If you need to do birth control, that's not estrogen. There are so many things out there. Actually, Paragard is one of the newest one in town. If you want to talk about it, you can text me and we can talk about it. Any questions about risk factors and all the things? Hopefully I've made it clear with breastfeeding, breast sucking, estrogen production, and all that.
Okay, Doc, probably I should throw in this first one. Thank you so much for all that you shared so far. It's been really amazing. However, when it comes to the risk factors of breast cancer, over here in Ghana, I don't know if it's the same picture in America, but you realize that currently most of the people being diagnosed, you really go through the history and you don't really find so many significant risk factors. We go through all these things every time. We know that most of them we cannot do anything about. Most of them are none, we can't modify them, but then we know there are a few of them we can modify. The question is, if a lot of these things we really have no control over, why do we still then always push the issue of risk factors? Because then people think once I don't fall into any of these categories, then I'm free in my lifetime. It's not possible for me to get breast cancer.
That is an awesome question. And if I may ask, what you said you're in Ghana, which hospital?
Okay, so my name is Grace Buckman. Okay, I'm the moderator.
Okay.
And
because I asked that because I'm going to be seeing some people soon, somewhere in Ghana, talking about this.
Oh, okay.
Yes, that's why I asked. So maybe we can talk later.
Okay.
And it's a very great question.
Okay, sure.
Because I actually recently, I think last week or 2 weeks ago, one of my students asked the same question because we happened to be at the clinical setting and a young lady had breast cancer who did not have some of these risk factors. And if you remember hearing me say, the one thing I asked was, okay, had this person been doing their breast self-exam? We will talk about that. That's one thing people don't do. So people may not fall into this. And going back to Ghana, I will tell you, most of us don't know our family history. Now, some of us are here, so we are digging it and we're finding out and we're sharing everything about me I've shared with my daughters. So they will know. I'm not sure if anybody can attest to it. How many of us on here, dependent, really know our parents and our grandparents what were wrong with them? Most of us don't know. So you ask them and they really don't know. So it will be documented in their medical history that they don't have these risk factors. But indeed, people do, they just don't know. Like, I mean, I am somebody, and like I said, I never mind using myself. Not since I've been doing oncology, and I remember asking my dad what killed my paternal grandmother. And the way he described it to me, and I asked my aunt also, it came across to me that she passed away in 1982 or 83. Based on the information I had and the knowledge I have now, I decided and determined that it was cervical cancer. So I don't play with my pap smear. You get my point. If I was not that nosy and asking those questions and questioning for us, since you said you're from Ghana, for us, it's difficult. Most Africans, questioning is just difficult for us. And even as I teach, my African-American students or African students, they don't ask questions like my Caucasians, even though we don't get it. So that, I think, is the best explanation I can give, that sometimes we don't know, or is just the reality now. So to that, we will talk about later, how many of us do breast self-exam. Then I will add my take on that. Hopefully I've answered your question.
Okay, thank you very much, Doc. I think I can see Caroline's hand up.
Okay.
So Caroline, you can go ahead.
Yes. Hi, everyone. Good to see you. Good to hear you. Thank you, Dr. Susan, for very well elaborate information that you've granted us this evening about the risk factors and breast cancer. I have two questions based on this slide that we are currently looking at. There's the point about having children after that 5 years of age or women who have had no children, what is the relevance of, how do you interpret this information? Does it mean that people are, what does it mean, especially, and what is the relevance of, for example, those who have had children? What added advantage do they have? And then the other question is about dense breast tissue. Yes, how does it come in? Are those people also with small breasts at risk, or what is the difference? Thank you.
Oh, I love your question. So first, your first question, having children after age 35, and I believe you said the ones who do not have children. The distinction there, it's really the longer exposure to estrogen. Remember this, that there are women who cannot have children for several reasons. They still do ovulate. Not that they don't. Most women who cannot have children, they still have ovulation. So that is the problem. You're ovulating, you're releasing more estrogen. That is why I made it clear, ladies, do not let the guys suffer, okay? So you can reduce some of the estrogen that comes along with ovulation. Women, once again, some women don't have children. Sometimes it's because they just cannot carry the baby, or they get pregnant and they just keep miscarrying. It could be for so many reasons. Just by the way, I have a little bit of background with women who have high risks during pregnancy. So there is something, so I'll throw that in there a little bit. Some women, they don't have children also because their cervix just keep opening. So they lose the baby. So if anybody on here has heard something called cerclage, they would do cerclage to tighten up the cervix a little bit and put them on bed rest so they can deliver that baby safely. So not that women who do not have children cannot, get breast cancer or in that reason, but they still get exposed through ovulation with the increased estrogen that they get as they ovulate. So hopefully that I've answered that first question.
Yes, correct.
Okay. The second question, thank you for asking, because I was going to elaborate on that. We take dense breast tissue as someone with big boobs. That's not what that means. That is not, before I became an oncology nurse, that was my thought. But that's not what that means. Dense breast tissue is actually measured. The density of the breast is measured during mammogram. So it's done with radiology. It's not something you can physically measure. So I just want to make sure we're clear. So the fact that somebody has small breasts, big breasts, that's a myth. I will tell you that, because the density is measured during mammogram. So that's my best answer for you on that one.
Yes, thank you. I think it's now
Okay.
clear. I hope it's also clear for everyone.
Doc, please, there are two questions in the chat box.
Okay.
I think the first one is from Udwak, and it says, what particular birth control method increases the chances of breast cancer, hormonal or non-hormonal, or both?
Hormonal. Hormonal, which is what I said. And I think these days, most people are doing away with the pills because people are busy. They can't even remember to take the pills. There's so many out there now, and I can attest to Paragard because I know about Paragard. It's IUD, okay, and it's if anybody's familiar with IUD, it's inserted by your GYN, goes up in the cervix, okay? And you should be able, as the female who has it, you should be able to feel it, but you should not feel it during intercourse. That is very safe because I can attest to that. But estrogen containing birth control pills, those really do raise one's risk of getting breast cancer. And even if you have stopped taking it within that 5-year period, you are still at risk because it gets lower as you phase out of that 5-year window.
Okay, thank you very much. There's a last one from Amma. It says, please, can you elaborate on metastatic breast cancer since we're talking about breastfeeding?
Okay, can I answer that question when I'm talking about the types of breast cancer? Remind me on that one, please, because I haven't even gotten there yet. Thank you.
Sure. Okay.
I think someone has their hand up.
Yes, this is Efua. Yeah. Yes, ma'am. My question is, does insurance cover that tests, Bracha or whatever you said? I didn't get it all well. Does insurance cover it? And can we literally ask to take that test, or you have to pay out of pocket to do that test?
That's a good question. So, this, I can answer insurance questions because for those of us in America. If you can present your case that you are at risk, it depends on the code. That's what I know because I'm not too familiar. That's a case management kind of question. And you can present your case that, hey, my sister had breast cancer. My dad had prostate cancer. That should be enough for your doctor to say, I can order this genetic testing for you. But you need to make sure, and I don't know what the code is. I get on my doctors. So you should be able, because it's patient-centered, you should be able to get onto your doctor, make sure they put in the right code. Because so for those of us living here in America, it depends on the code that your provider puts in. That's how you get charged. So if you can present your case that you are high risk, you should not be charged.
I see. Thank you so much, Dr. Koduah. This is my first time really hearing some of the things you have just pointed out, and I really appreciate you taking your time to do this. So God richly bless you. Thank you.
Amen. Thank you.
This is Lawrence with the insurance question.
Oh, thank you, Lawrence.
Yes, ma'am. If it's medically necessary, especially in the US, yes, it is covered. It's a covered expense. So as you said, it is how it is coded. If it's coded as diagnostics, then you probably are on the preventive side. And if it's diagnostics, then you are paying deductible co-pays and whatever. But if it's coded as preventive, then it's medically necessary. So you probably will not pay that much, but it's all in the initial stages. So if it's your first time and it is coded as preventive, insurance is covering it almost at 100%. But if it's diagnostics, then you probably incur some co-pays, co-insurance, and so forth. That is my take.
Thank you.
Okay, there's another hand. Harriet Bortsie. Harriet.
I think it had network drop.
Okay. I'm still on the insurance. Before Doc, you go ahead. For Ghana, our national health insurance doesn't really doesn't cover it because there are just a few private centers around that do the testing. Notable is Lancet. They do the BRCA 1 and 2 testing. However, for your private insurance, some of them can cover, but then I think it's still the same in the US as well. Your doctor really has to give the go ahead. So it has to be clearly written on a request form for you, and it has to match whatever suspicion that your doctor has. So I think basically it's the same picture here.
Yes. So to that, I will add, just in case I forget, and I will say this since we are on here, that was my friend Lawrence who explained to us. So if you have any questions about medical insurance and stuff, contact me and I'll connect you to him so he can guide you to get the right insurance, either medical, whatever have you. So that's that. it has to be documented appropriately. And once again, I remember when I had my very first mammogram, just as Lawrence explained, that one was preventative. So I did not have to pay anything because that was covered. Just so I'm saying this so we will all understand what this means. But because initially they saw some what is called calcifications, because they had no other imaging of me to compare it to. So then my second mammogram, which I was doing every 6 months, my God, thank God I don't have to do that anymore, because now they have enough images to determine that it's just calcifications. That became diagnostic. So I had to do a copay. So I'm a practical teacher. So I just wanted to make sure to illustrate this to you, that if it's preventative, my very first mammogram was covered 100%. But because of what they initially saw, it became diagnostic because they had to do a more in-depth mammogram and ultrasound. Somebody may have that question. We could probably talk about that later. That became diagnostic because they were doing further investigation of my breast and what was going on. Hopefully this is good for everybody and we can move on. See all the risk factors. Or does somebody have a dying question on risk factors that we have not answered? All right.
There's another question in the chat box, but I think it would fall under the signs and symptoms. So probably when we get there, I'll read it.
Okay. All right. I think Harriet is back and has her hand up. I think she was going to ask something and she dropped.
Yeah. Hi, Harriet. Okay.
Okay. I'm not sure if she's hearing us. Maybe she can ask, at the end we'll do general questions. So, oh, she's on.
Yeah. Hi, everyone. I came in late and my question, I don't know whether you already answered my question. My question was on the raising of your estrogens. Yeah. I wondered whether maybe the types of food that you eat and maybe exercise, are there factors that can help? And is there a way that you can know your estrogen level? And maybe the foods, if you eat the right food and exercise, can it help to bring it down?
Okay, I will thank you for that question. This question, I will answer it generally in the sense that exercising is good for everything. So once you start getting into, remember, one of the risk factors is obesity. Once you get past, based on your height and your weight, what is called the body mass index, one could be obese. I remember talking to one of my colleagues. I am taller than her. She's just a little heavy than me. She's like, Susan, can you believe my doctor said I'm obese? I said, really? I was shocked. So if you don't know your BMI, please Google BMI calculator and it will tell you based on your height and weight if you are obese or not, and you'll be shocked based on your height and weight. So exercising is good. That can help. Is there a particular test that checks the levels of our estrogen? Not that I am aware of, but I know typically when one is diagnosed with breast cancer, they check for the negativity or positivity. But as to, it's either negative or positive. As to the levels, I am not aware of a particular test that check for the levels of estrogen. If somebody knows that, please share, because I am not aware of a particular test that that test for that. What was your other question? I may have missed it.
My other question was the type of food that you eat.
Okay, so I always tell people, and people that know me, they know this about me. Everything in moderation, okay? Don't eat too much of one thing and less of the other. So look at this is where I bring in my food and nutrition from those days. Get the plate, see how much of your veggies you need, how much of your carbs. You need protein, okay? Eat protein, and with protein, your beans could be proteins, eggs, not too much red meat though. You see, I personally don't care too much for red meat. Don't do too much red meat. Where we're from, a lot of us do too much red meat. So that I will say, if you're one of the kind, cut back. I remember talking about, I think it was cervical or prostate cancer. I was doing this in Ghana. And one of the guys, and we were talking, just like, hey, this is something, this is something. I don't know how I can cut this out of my diet. I said, well, you're going to have to. So everything in moderation. That's my response to that.
Thank you.
You're welcome. Okay, I think we will move right along. Hopefully we have exhausted our questions on risk factors, because that is why we are here, right? Reduction. Signs and symptoms. I am a visual learner, and hopefully others are, so I like to show this. You can see it for yourself. Lump in the breast, armpit, nipple discharge, changes in breast appearance, itching, red, swollen breast, pain in the breast area, nipples become sensitive. These are some of the signs and symptoms. They can also be signs and symptoms of other things, okay? This is just general. But if you continuously see these things, you should be talking to your doctor that you are frequently experiencing this. And currently, it bothers me that I don't know about Ghana, but here in the US, there is a controversy regarding should people be doing breast self-exam or not. Please, you will hear even some providers that, oh, you don't really have to. Please do. Please do check your breast, women. If your partners can check it. So remember, we talked about the estrogen now. We're back here. Let them check it for you too if you can't. You check it in the shower. You check it when you're laying down. Check it, check it, check it. I may have it on another slide, but how you want to do it. If you are a woman who is still having your period, okay, I'm tying you checking your breast into the signs and symptoms so you can feel the lump. If you are a woman who is of childbearing age or still having your period, it should be about 5 days following the last day of your period, because that's when you all know how your breasts feel when you're having your period, right? You all know how it feels. So between that 3-5 days, it's not as sensitive and you can actually feel it. If you are a woman who is postmenopausal, remember people, I had a patient, she was 80 something when she felt her lump. That's how she got diagnosed with breast cancer. It wasn't even mammogram. She was 80 something and still checking her breast. So if you are a postmenopausal woman, then pick a day in a month that works for you and check it. We got that?
Yes,
Are
please.
we clear on that? Okay, good.
Yes, yes.
I just want to make sure we don't miss that. So you are to check, and I know at least 3 people personally who got diagnosed with breast cancer because they felt their own lump. Because you may not be at age 40, which is when mammogram, you get tested for mammogram in the US. I don't know what it is in Ghana or other parts of the world to the other viewers or listeners on here. But in the US, it's 40. So you may not be 40. So if you're waiting to get your first mammogram at 40, you could have something going on if you're not checking yourself. Yes, and you know what? Most of our women also don't see their GYN every year. Please, if you are that kind, don't do that. As a woman, especially of childbearing age, still producing estrogen, progesterone, please see your GYN on a yearly basis so they can officially check you out. And going back to the 40 years, if you have a family history of breast cancer, let's say your mom had it, your sister had it. In the US, you can do your first mammogram 10 years before. So please take note of that. You can do so that 40 years will not apply to you because you are in the high risk category. So then you can request for your mammogram, making sure your doctor documents it like that so you don't get charged. You can get it done at age 30 if you are here in the US. Any questions about that?
Okay, Doc, not really a question, but I just wanted to throw in this in terms of the screening here in Ghana. So one of the things we are pushing for is for the breast self-exam to even start at a very early age, as early as 20 years. So we push for, and as you rightly said, from 20 to 40 years, we push for 5 to 7 days after your period. And then after 40 years, we push for just taking 1 day in a month where you are doing it consistently. And I think now the other thing we are pushing for is the less than 40 years, even before your first mammogram, we're pushing people to be having ultrasounds once in 3 years. We know it's not necessarily a screening modality, but once you're having the breast self-exam yourself, we encourage less than 40 to still see a doctor or a nurse or a medic to do it once in 2 to once in 3 years. And then you do an ultrasound, even before you get to your 40, and then you start your mammograms.
Okay.
And I think that has really helped. Yeah, that has.
So,
Doc, I have a question.
Ghana, our folks in Ghana, Grace shared with us what's going on. If we have other people from across the world, different countries, if you know of what you're doing in your country, please feel free to share that also. So in Ghana, you guys still start mammogram at 40 in Ghana?
Yes, at 40, yes, at 40.
Okay, so for my US folks, before an ultrasound will be done, it will be after mammogram. So I'm not sure, Ghana follows a thing which is different from US. So just so we understand what is going on with us in US. If they suspect something, that's when they would do an ultrasound over here in the US.
Doctor,
so I just wanted to add that.
Can I share something?
Yes.
Okay, so my sister died with breast cancer when she was like 43. So it's a history in my family.
Who is speaking, please? I like to connect.
I'm so sorry. I'm so sorry. This is Rosemont. I'm sorry.
Okay. Okay, Rose.
I was working and I muted myself. I'm sorry. So my contribution is I started doing a thermography at early as 30 years. Mm-hmm. And it can also detect if you have a breast cancer or if you have a lump. So I know in Virginia, there's a center in Fairfax and there's a center in Winchester. So if you're in Virginia and you have that in your family line or history and you want to start, that's another thing you can also do.
Thank you, Rose, for sharing that. So there you go. Family
history. It has a less radiation. So, a healthcare provider recommended that.
So if you want to know more about that, also, you can connect with me and I can connect you to Rosemont if you want to know more about that. Any other question before? Oh, there are two people's hands up. I think Lola and Caroline.
Yes, Lola, I think you can start.
Yeah.
Okay, Caroline, go ahead.
Hello, everyone.
Hello.
Hi.
Okay, can you all hear me? My name is Lola Tanimo. I'm glad to be here. Thank you, Ma. God bless you. Wow, so insightful. I really appreciate you. God will continue to enlarge your course. Yeah, thank you, Ma. Please, I would like to ask, is every pain on the breast suspicious, or is it that it has to be, I don't know, is it that once you have pain on your breast, you should run to the doctor, or it should be that it is, I don't know how to explain. Is every pain suspicious?
I think I get your question. Thank you. So this is where I always tell people, learn to know your body. That's something we don't do as most of us humans. I think I have started learning to know my body more, that sometimes it's overboard as a nurse, but it's good. So that way you can tell when something is not right. You will know that this one there, I need to go ask my doctor. As women, sometimes when you have your period, the experiences that you have vary. You can have, some people can have breast pain really bad during their period. Some people can have it bad during ovulation. You should know that, and you should be able to differentiate that from when nothing is going on. So if you're really having breast pain, sometimes it may come with redness or the swelling. Then I will suggest you see a provider, because that's what they've been trained for, so they can do further examination to determine what this is about. Like I said, I never mind sharing. If you are breastfeeding, that's the time you want to also pay attention to your breast, because when people have breastfeeding, that inflammation that goes on, when a woman gets really engorged, there is not much massaging going on. That's why you need to massage and get your breast massaged so there is less estrogen. That for some people can lead to breast cancer. And sometimes I sit here and I break down, because I found out a few months ago that a cousin I don't know got breast cancer, which started with that, but I never heard of it. And it's kind of too late now. So please get to know your body. That would be my biggest response. In all you do, know your body, so you can tell when this one here is not right. This one is not right. I need to go see a doctor. Same thing applies to, like, if you're taking, like I was taking some medicine and I started, after 3 days, I could not go up the stairs. I'm saying this, we're talking about breast cancer, but for me, when I'm teaching about one thing, if I find it necessary to share knowledge about something else, I do. So hopefully that's not a problem. You should know that, so that it's important when you're taking stuff to know the side effects. And I remember that that particular side effect that I had typically happens to old women. So I'm like, I'm not an old woman. I couldn't go up my stairs after taking the drug for 3 days. Then I realized that obviously you will say it's because I'm a nurse, right? So I do the, but not always. I'm saying this to emphasize on why it's important to know your body and know what you're taking. So I have added that drug to my list of allergies, because I am not taking it, because I don't know what will happen to me next time. Does that make sense? Because I know my body. I was like, no, how is it that I cannot climb the stairs? And I realized it was that medicine. So that's that. Okay, we see a lot of hands up. We will take them.
Caroline.
Yes, thank you. Thank you, Grace. Thank you, Dr. Susan. I have a question actually on ultrasound. So the question is, if your ultrasound results show some fluid in part of your breast, but no discharge so far, does it allude to signs of breast cancer? Is it
okay? Let me make sure I get the question right. If you do ultrasound, but you're having discharge of the breast, right?
No, the results of the ultrasound indicate that you have fluid in your breast.
Oh, okay, I got you.
Yes.
Okay, no. So sometimes some people will have cysts. Some people can have cysts. Some people can have pocket of fluid in the breast. So that is when it depends on your provider. They might then say, let's do a biopsy to see what is in this fluid, or if it's a cyst. So it depends. It does not, see, until a biopsy is done, we cannot confirm. So that is the bottom line. So for confirmation, a biopsy will have to be done. Does that answer your question?
Yes, thank you.
Okay.
Isaac Olofi, please go ahead.
Can you hear me?
Yes, we can.
Hello. Okay.
We can.
I'm Otumba Isaac Olofi, Nigeria. I want to appreciate you for this lecture, and I'm on the preventive side. For instance, you're not aware that your wife or your partner is having breast cancer, and you have, in the process of having intercourse and what have you, you have to suck the breast and what. Is it going to affect the man, or it has no bearing?
Okay, let me make sure I got your question right before I can answer. If you are not aware that your wife has breast cancer, I think that was the first part, right?
Yes.
And then you suck the breast. Was that the second part?
Sure.
You suck the breast. Can it affect you, the man? Was that your question?
Yes.
No.
Yes, please.
It's not as contagious as you would think, not in that respect. So no.
Okay.
You are actually helping the woman by massaging and sucking to reduce their estrogen. Unless if they are going through chemo treatment, then you should not, because that will be body fluid. Then you will be getting exposed to chemo, but not the cancer. So women, and I know this is not just women, this is just most of us on here, African thing, that when something is wrong with us, we don't even tell when we're sick. Sometimes your partner don't even know, more or less the rest of your family. So let's shun away from this kind of behavior. So Mr. Isaac, hopefully I answered your question.
We have two more hands up. Susanna Chum, can we have your question, please?
Hi, hello. Hi, everyone. Actually,
hello.
Doc, thank you very much for this. This is so amazing because mine is not a question, it's a contribution. I work for an insurance company, right? And this is what I'm seeing with us Ghanaians. We do have the care because it's proactive in most of the insurance companies, but they don't come. They don't come. So every Ghanaian that I tend to take care of, it's like they're on their last straw. So this is so educative. I cannot thank Doc enough because we've lost so many Ghanaians this way because they don't know. They have a free insurance. You just pay your copay. With me, I work for Kaiser. It's preventative. It's proactive care. So it's free. Actually, it's free with my company, my insurance. It's free, yet still I have Ghanaians sitting there with their last straw. Basically, it's like it's the end. So let's just be aware. Let's ask our doctors, even if it's has to take money, pay it because it's better to stay alive than to die. So let's just be more proactive about our health. It is very important. Just like Doctor said, I have been to funerals where people say, "Oh, Bibianya no, Bibianya no," and because of HIPAA, I can't. I'm like, really? We are always the last minute folks. So Ghanaians, please let us do more. Ask your doctor. Take that day off. The money. So the work needs to lay a little bit, and you take care of yourself. Because when you are healthy, that work can follow. But if you do the work, I'm building in Ghana, I have this project in Africa, I have this project in Africa, then you tend to slip away. Then the building is staying there, nobody is enjoying it. Somebody is enjoying it for you. Let's take care of you. You is very important. Thank you.
That was awesome. So that was my baby says, just baby Susan added that. Thank you, thank you, thank you. So let's take care of ourselves.
We have another hand up. Ifya Yankoba.
Hi, thank you so much for allowing me to ask another question. Dr. Koduah, my question is, does wearing underwire bra, does it cause any breast cancer condition? Can you get breast cancer from wearing like underwire bras?
All right, let's see how I can best answer that. So just so everybody knows, everything I am presenting here is based on research. So if I don't know, then I don't know. So I actually haven't found a study. If somebody has, please feel free to share that. I know I've heard people say that, but I do not have the evidence because as a researcher, I talk and practice based on findings that I have read and heard of, but I haven't. If you have, I do not know every single thing in this world. Please share that. What I know though, if you come to think of it, is, just taking care of yourself. Make sure because a lot of people don't wear the correct bra size. So come to think of it, think of the tightness. Your breast can get tight and gorge. It doesn't get the massage that it needs. So that I can say wear the right size bra because some people don't know their bra sizes. And because they just want to either pimp it up or I don't know if I'm using the right word. But that's the response I can give. I haven't found a study talking about if underwire bra adds to breast cancer or put one at risk for getting breast cancer. If you do, please share with us.
Okay, and so the other thing is, when you go through breast reduction or like making your breast bigger, does it give you the chance? Does it expose you to breast cancer?
Once again, to that respect, I honestly don't know what they do with those cosmetic surgeries. So I may not have the best answer for that because they are putting in so many things and adding things. I don't know what they do. If I come across a research with breast reduction or those cosmetic surgery and its impact on breast cancer, I'll be more than happy to share with Dr. Sam and he can share with the team.
Okay, thank you.
Thank you. There are
Doc,
two more hands.
before you go, there's one quick question that I need a clarification on, which is, I think previously you had mentioned that the men should stop sucking the breast so that the wives will not have enough estrogen. But when you were responding to Isaac Olofi, you said sucking the breast rather helps them. So there's a bit of a confusion in my mind. I want to be sure.
You need to suck it. No. Yes. No, you need to. Let me make that disclosure very clear.
Where's my wife?
Doctor, don't worry. I'll make it clear to her.
I know your wife is on there, so I know now all day is on here. So please, yes, you do. I think Mr. Isaac's question was, which how I said it got you confused. If the wife is going through chemo, then no, because you'll be exposed to chemotherapy because breast, you don't know what may come out of it. That will be an exposure to body fluid. But please, you should massage and suck it for less production of estrogen.
Thank you very much. The men love
all
you. All
right.
Doctor, can I say something about the Sister Fia's question about the wire bra and the...
Yes, go ahead, Tina. Thanks for joining.
So, this is Rosemont. So The reason why I stopped using the wire bra is one time I cut through my bra, right? And the wire was so rusted that it scared me. This was about 6 years ago. So from that time, I decided not to use a wire bra. So I don't know if you feel comfortable wearing a bra and it's all rusted. You have a metal that's rusted and you're putting this on your body every time. So for me, that's why I stopped using a wire bra.
All right, that is her personal thought, remember. And we won't get too much into that because I'm not sure how long it had been. So that could take us another day to talk about the wired and the wireless. I think Tina has a question.
Yes, I do. I am having a great time. Thanks for the invitation. My question is, I see a slide that you're about to talk about with the self-examination. It helps, since you started talking and answering questions, you've been mentioning how the massaging helps with the estrogen level. The lower the estrogen, the better. So our husbands, those that are wives, our husband massaging and sucking, it's helping. What about the single ladies? What about those that are not married yet, or even married but divorced? How do they get that, sucking or massaging if they are single? Is that just
Oh gosh. So anyway, that's a deep question. So this will be my own analogy. So the ones who got people to massage for you, you are at a greater advantage because you do it every month. And then however often you're being intimate with your spouse. So you are at a greater advantage because you are producing less estrogen. But for women who are not active, then you should be really, really doing it. This slide I'm not really going through. It's just there for you to see. If you want me, if you want me to show you, if you are in this area, I have my demo. I can show you how to do it. Then you should, when you are checking and feeling for it, you should follow it as it's being done here. Go around it and massage it. If you don't have somebody doing it, obviously you're single and not active with anybody. That is, your estrogen probably will not be as lowered, but that goes to, you then need to do it. So let's have it the basic of doing it every month. Okay, because like I said, I don't know how often people are intimate with their partners, or there are some women, especially our people, the breast really has become like a no-go zone. That's why I said stop that. Okay, it's all part of it. Stop it. It's like you can go other places, but not the breast, and then they'll tell you that's for the baby. That I can prove to you. I can give you articles on that. So I will end it as that. So hopefully, Tina, I have answered your question that you are at a greater disadvantage because you have some advantage. Sorry, you are at a greater advantage because you have somebody if you let them go to that zone.
Thank you.
Okay. All right. So this slide I just wanted to show you. So let's get through it. Diagnostics. I think I already talked about that. Based on someone had asked a question to confirm that one has breast cancer, a diagnostic has to be done by taking a tissue, which is breast biopsy, needle breast biopsy. That's how it gets done. Sometimes you do MRI, PET scan, depending on how far out they think the cancer has spread. Then they'll do MRI and PET scan to check for metastasis. Now we get into the breast cancer collection itself. So remember on slide 1, there's a reason why I showed you the anatomy of the breast. So the milk ducts, this is what you will hear, or if you read physician notes, if you get to these days, I think it's been a requirement. If you go see your doctor, go to your chart and read what your doctor writes about you. I remember one of my students saying, Dr. K, I'm very sad today because I read in my doctor's note that I'm obese and they did not tell me. So go in and read what they write about you, because it's not all the time that they will explain everything to you. So this ductal carcinoma in situ is confined to the milk ducts. So with that, sometimes it's not really considered, as cancer, simply because it's so confined, but most likely it will come back in 5 to 10 years. Some women will choose to do lumpectomy or breast conservation, radiation. It depends. Breast cancer treatment actually, as of right now, is a decision between the patient and the physician. To be precise, the oncologist, okay? Some women will be given tamoxifen. And this is where I see our people, because I remember years ago when I did full-time at the bedside, one lady was from Ethiopia. I don't know how far she was when she was originally diagnosed. She refused treatment here and went to Ethiopia, And then when she came back, it had already spread, and she was still not really for, even when it spread, there is still stuff that can be done. And she's like, my sister from Ghana, what do you use in Ghana? I said, please, I don't know what they use in Ghana. I live here, I work here, and I know what they use here. That's all I can tell you. The different, so many different treatments out there. So for this particular one, if the person is postmenopausal, they cannot take tamoxifen, then they have to take what is called an aromatase inhibitor. Because breast cancer is all hormonal, and treatment is very targeted. So every type of breast cancer the person has and the treatment that they get, long-term survival for this is 100%, as you can see. Invasive ductal carcinoma. This one it accounts for a lot of breast cancer, unfortunately. Every time I read a chart and I see this, I said, may God help us. And may God help the person, because it becomes sad, because you kind of, everybody's gonna die, don't get me wrong, but when the person is starting off with bad prognosis because this is the type of breast cancer they have. And if you think back to when I talked about the different hormones, the estrogen, progesterone, the HER2, that's what this slide is about. So when somebody has triple negative or inflammatory breast cancer, it means their estrogen receptor is negative, their progesterone receptor is negative, their HER2, which is the protein that helps control breast cancer, that's also negative. If anything, you want them to be positive. You want them to be positive because treatments out there that are targeted is favorable for people with positive hormonal type of breast cancer. The negative ones, there is not that many drugs out there, even here in the US. Now, cancer research is so advanced that we actually have a lot more, but they use most of the positive drugs to treat the negative because it's not a lot of drugs out there. So if you know of someone who has triple negative breast cancer, it's good to support that person, have them ask a lot of questions, because there is not a lot of treatment out there. And as you see, it accounts for 80% of breast cancer. Most people that I know, most Black people that I know, have triple negative. I'm not sure why. That would be something else that I'll have to look into, but I cannot answer if you're thinking of asking me a question on that. So it moves from the milk ducts to the fatty tissue. So fat, it feeds, if you think of it, the fat feeds into around the breast. So then it becomes more invasive, which is why it's invasive. So the treatment can be lumpectomy or mastectomy. If you ask me for advice, if you know of somebody that has triple negative, please tell them to do mastectomy, not lumpectomy. Because mastectomy, they take everything out. Lumpectomy, they just take the lump out. You still have blood vessels and stuff, which could be feeding some little cancer somewhere. So just let them cut it off. And this is the standard chemotherapy regimen that we use to treat triple negative ACT. It's a combination of 3 drugs. The A is adriamycin, and that can be tough on the heart. So usually they have to get an echocardiogram, like a picture of the heart, to see if the heart can take that drug. Cyclophosphamide, that is tough on the kidneys. So we got to make sure we are encouraging them to drink a lot of fluids in the hospital. This is outpatient treatment, actually. So they are usually given a lot of IV fluids. The biggest monster of all is the T, which is Taxol or paclitaxel. That, and I get a lot of calls from people that I have gotten close to who have breast cancer. One big side effect of the T, which is Taxol, is peripheral neuropathy. Peripheral neuropathy in the sense that the person, and it's mostly in the feet, they might have some tingling or numbness. So when people call me about that, I ask them, is it tingling or is it numbness? Can you feel the sole of your feet? If you can't feel the sole of your feet, that means the neuropathy is really bad. I remember I used to work with one of my coworkers who had breast cancer, and every cancer patient, irrespective of breast or any type of cancer, they are afraid of dose reduction. Because, you know, the less chemo you get, your less chance. But sometimes the side effects is really bad. If this neuropathy gets to where the person is falling and they cannot feel their feet, that's probably as bad as the cancer. So this one girl, you know, she lived alone, and I think she fell in her tub. Thank God that she survived it. But I told her that she will not mind me mentioning her name. I said, Pat, this is so many years ago. This is bad. And we worked together. I said, you knew this. So why didn't you tell your oncologist so they could do a dose reduction for you? So it's very important. So this neuropathy can get to where people cannot even walk because they can't feel. But just a little bit of tingling here and there, that's expected when somebody gets the T part of that chemotherapy, which once again is paclitaxel or Taxol. So it's very important that if you know or you're close to someone who is going through any type of chemotherapy, get close to them, ask questions, be their support system, if only they've opened up to you. And I use this opportunity to tell people, let's stop living the African way. I know people are like, she's gonna tell my story to somebody. So what? I have a friend right now battling stage 4 ovarian cancer. I think the support she's getting from all of us is helping her fight her cancer, because her last cancer marker when she was originally diagnosed was like in the 14,000. The most recent one was like 3,000 something. And she has strong faith. So the support we are all giving her in the faith, I think it's working for her. Every week she's about to go for chemo, she puts it on Facebook or she will text me. And we need to start kind of living like that. Nobody should be going through cancer treatment alone. It's depressing. It changes people's demeanor and their look. From the moment I think somebody gets told they have cancer, it's very depressing. I mean, I've done this almost 20 years. It's tough. I will not lie. It's tough, but you know, we got to be there for people. So anyway, that's that. I'm spending so much time on this because this is the one common type of breast cancer that we see. Person depending maybe on radiation. And sometimes with the chemotherapy, you may have heard that there is adjuvant or neoadjuvant treatment. Depending on the size of the tumor, they may do chemo before. So that is the neoadjuvant treatment. And then they will do adjuvant after surgery to continue with the chemo. So if you've heard these words before, that's what they mean. Neoadjuvant is before surgery, and adjuvant is as post-surgery, they continue with treatment. Any questions about invasive ductal carcinoma and triple negative breast cancer? You know, that was a mouthful.
Doc, mine is not necessarily about these two, but about your experience with tamoxifen. I know now there's been a number of studies in terms of prevention of breast cancer in high risk populations. Is this something that has started in the US, using tamoxifen generally as a preventive drug in groups that are found to be at high risk?
Actually, no. I think I've heard of that, but that's not something that I see as common practice over here, unless the person has shown or confirmed. Like if you go back to the very first one, if they have ductal carcinoma in situ, they may be put on tamoxifen, but not just standard like people take aspirin to prevent stroke. No. Does that answer your question?
Okay, yeah.
Okay. 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 Remember, there were lobes as part of the breast, right? So this is lobular carcinoma in situ. I say this because if you know somebody, when physicians write their notes, so you can understand that, oh, I heard or I came across this word in the chart. So it will make sense. So this is the lobes, the glands that make the breast milk. This one is also, because it's also not considered cancer, is 25% risk. It puts one at risk. So this is where the mastitis folks fall in, if people pay attention to their body and, you know, see what's going on. It's here, if you pay attention to your body and you and your doctor find out at this stage, it's just usually frequent screening to make sure things are okay and they don't need to go through anything. HER2 positive breast cancer, once again, is the most common. And as I had already mentioned, because it's part of the triple negative, I just wanted to highlight it. And it just carries too many copies of cancer cells. It doesn't stop. When somebody is HER2 positive, it just keeps producing. You can't stop it, but they do have drugs that can stop it, which makes it difficult when somebody is negative because there is not a lot targeted therapy for that. Metastatic breast cancer. I think someone had a question on metastatic breast cancer. So this is it. Due to leftover cells, they have just outgrown and now they have gone to organs. Lung, liver, bone, brain. I usually ask, brain is the most common. I remember asking one of the breast specialists that I work with, I said, Dr. D, why is it that when breast cancer, and I hear this a lot, and you may know people actually who have had breast cancer and it comes back and it goes to the brain. Maybe someday I can do a research on it. As it is right now, I don't get it. The only way I can get it is the proximity of the breast to the brain because it's up here. Because if you look at GI cancers, stomach kind of cancer usually do not metastasize to the brain. So that's what makes me think of the proximity of the breast to the brain. So if you're thinking of asking me the question why, that's my personal thought on that. Maybe someday there will be research to support that. So lung, liver, bone, brain, gone to all these organs. That is metastatic breast cancer. People are living for years now, just so you know, because, I mean, at least here in the US, I don't know about Ghana, because I know I go to a meeting once a month, every Monday. I cannot keep up with cancer research and the drugs that are coming out now. I can't. So many. I should probably say we thank God for that, because there are a lot of researchers out there who are researching into this terrible disease. And breast cancer actually has a lot of new drugs that keep coming out by the month, by the days, by the year. So I guess we can ask the question. Grace, you said someone had a question on metastatic breast cancer.
Yes, that was Amma. And the question was, how do you relate metastatic breast cancer and breastfeeding?
If she can clarify that question a little bit for me, I would love that.
Madam President, Amma.
Hello. So it was a question someone had put in the chat, and I just copied and pasted it to you, Dr. Grace. So I'm not sure if the person is still on.
Yeah, if the person is still on, I would love for them to ask.
So I will look and then.
Okay. All right. Okay, yeah, then we can answer it appropriately. Anyone has a question on metastatic breast cancer while we look for that question? Okay.
My question is it's really on the survival rates. You rightly said that out there in the US, there are a lot of advancements in terms of treatment. But for instance, when you look at Ghana, if you're looking at the stage 3, stage 4, survival rate is reducing up to about 22%. But I know that it's better in America. What do you think would account for this? The difference in survival rate when it comes to breast cancer treatment? Because we know here a lot of people are definitely presenting late. Up to about 70% of the cases are coming very, very late. That can also account for it. Even the late stages, when you compare the survival rate here and out there, you realize that we are still not doing good at all. And really the question is, are there things we are not doing right here, or like what exactly?
Okay. This is very funny, Grace, because that's why I asked you if you're associated with a hospital, because I get calls. And I know, like recently, one of the calls that really broke my heart, we all know motherland, it's about money. I was told that day I did not know what to do, and I will be visiting that place. The person was diagnosed, which, I think you asked this question specifically for Ghana, I think. So that's why I'm going to give my honest feedback. It's sad that our leaders, because here in the US, you're not going to go to any emergency room and present with any type of cancer and somebody turn you away because you don't have insurance. No. So this call that I got was a young lady, I think 31, in her early 30s, who had initially, I don't know how long ago, had presented and diagnosed with breast cancer, but because they couldn't afford chemotherapy, because I've been told, because, I have people there that I talk to pretty often, that, dependent of, it's about 1,000 plus Ghana to whatever plus Ghana, depending on the drug. Who can get that? I mean, chemo treatment here is very expensive. Don't get me wrong. I mean, most of my patient population is also leukemia. I know by the time a leukemic patient leaves the hospital, they've clocked close to $200,000. You think they're going to worry about how they're going to pay $200,000? No. So that's the problem. I think that's part of the survival rate issue in Ghana. Do we have it? I have a slide on survival rate for US. So it's sad. So then this person initially, remember when I talked about the breast, I said the areola and the nipple, when it becomes like the tumor outgrows, it comes out and becomes a wound. So the call I got was the person now has started bleeding because the tumor is now out, which is very sad. And I think we have a lot of those in Ghana. And my own cousin that I'm talking about went to, I don't know how she presented, which breaks my heart. But she was sent out from Confanoche. She was sent to go home and just die with nothing. She was, by the time I found out, it was late. So unfortunately, it's hard. But that's that. And she's early 30s also. It is what it is for motherland. That does not, we just don't do any much to help our health system. So I think that's my response to that.
Okay.
So hopefully I answered your question.
Yes.
Okay. Maybe you have connections to the government.
I mean, I wish I did. Sometimes it's really heartbreaking. This month we've been doing a lot of talks here and there. You see young people, and I really agree with you. Most of the times it boils down to money, because you push people to come for screening, even the investigative modalities, you still have to pay for it. The national health insurance will pay to a point, but even your treatment, it will not pay up to a 50%.
No, I had it's nothing.
Yes, it's sad. So after pushing these people to get screened and get treated, you realize they get to a point where you really cannot help them again, because now it gets to the point where money is a big issue.
Yeah.
Yeah.
Well, all of us on this platform, we have work to do, because I have work to do next month when I go home.
It will be definitely very good to link up with you.
Yes, yeah. Let's connect back door. Get my number from Dr. Sam.
Yes, I will. I thought the two of you work well. Just Dr. Susan, for you to know, Dr. Buckman is the medical director at Sonotech in Ghana. So she has a big hospital.
All right.
Yes.
All right. I'd love to meet you there.
Mm-hmm.
Okay, I think someone's hand is up. We'll take that. Then did we find the metastatic breast cancer question or not yet?
The person said it was clarified when you spoke, so we don't need to go into it.
Beautiful. I must have done a good job. Okay.
If we're Yankoba, your hand is up.
Yes, ma'am. My question is towards the last person who asked the question. I want to know whether, I know we have in Ghana, there are a lot of herbalists that do well with treatment. Sometimes they work, sometimes they don't. But there are some legit herbalists that I feel they're okay. So is there any collaboration with the Ministry of Health and these herbal doctors, and are they looking into some of these herbal medicines that can really treat cancers, especially? Is there anything like that going on between the Ministry of Health and these herbal doctors to come up with medicines that can help treat some of these cancers? Because just as you said, when it comes to hospitals, most of them don't have money. And I know when I was in Ghana, I was with the Ministry of Food and Agriculture. And so I came across some herbal guys who were deep down in the villages when we used to go there. And so my question is there any collaboration with the Ministry of Health trying to work with some of these herbalists? Some are really renowned, to see if there's any cure for cancers.
Is that question for Doc?
No,
I don't know, but I might be able to answer.
It's not for Dr. Susan. It's for the counterpart
for Dr. Buckman
from Ghana. Yes.
I mean, I can't say for sure if there's anything going on with the ministry and the herbal community, but I know definitely as it stands now, the herbal community is one of the biggest problems when it comes to breast cancer treatment, because you get people diagnosed early and then they go to all sorts of herbal camps they then return back to the hospitals at a very late stage where their treatment options are quite limited. So as it stands now, for herbal, it's a big no. And we are really pushing for people not to resort to it at all once there is a diagnosis of breast cancer. However, I really don't know whether the ministry is encouraging any backdoor investigations into any herbal products. Yes.
I think I don't live in Ghana, but I can answer this question some. Since I go pretty often. And my uncle used to work with the Ministry of Health, so I kind of have asked some questions. And remember I talked about, and I really agree with Dr. Buckman, because people hear about this herbal thing and that's their first alternative. So in response to your questions, this day, for even here in the US, we don't tell people not to do that, but that's not the primary treatment, which is what the problem is with us Africans. Here we call it complementary alternative medicine, CAM, complementary alternative medicine, which the president needs to talk about if you're seeking that in collaboration with the oncologist. And remember I talked about my cousin, right? That was the first thing she did. And I hear that there is some lady in Kumasi, some herbalist, which Dr. Buckman, you probably are aware, you know who I'm talking about. Some lady. Apparently, she went to see this person first. And by the time she presented to Confanoche, it was bad. That's the problem. They are just these herbalists, they are abusing the system. They are abusing the system because they're taking side money. That's how I see it. Because when I go home, I get very nosy. You know, I talk to different people and ask different questions. That is the problem. But, you know, just to say that is not the primary treatment when it comes to cancer, though. I've had people ask me, there is this fruit. What is it called? You may know. They asked me and I said, I don't know.
Soursop.
Something. It starts with an A. Aloe something. Not aloe vera. Aloe B something.
Yeah, aloe vera. Yeah.
Not aloe vera. Aloe B something. I don't remember the name. They asked me and I said, I don't know what you're talking about.
Alugum tugum.
I think so. Yes. That's it. Yes,
yeah,
that's
it's the leaves for, you know, when we were growing back in Africa, that apple that has a thorn on it.
That's the soursop, he said. That's the soursop.
Yes. Oh, okay. Yeah, that one. I said, and once again, like I say, when I do these presentations, guys, I am doing it purely from research perspective, not my own mind, not what's on Google. It's purely research. So I did not have enough evidence to give them a response on that. So that's what makes it difficult with there are so many, and there are so many herbal drinks. Oh my God, so many. I think the drinks in the country from the herbal people are even more than the population. So anyway, we'll leave it as that. I think Francis, and let's take one from a guy, I think.
Francis.
Okay. All right, thank you. Can you hear me?
Okay, it's better now.
Yes.
All right, so my question is actually on this stated fact on cancer generally, that it is the absence of vitamin D17, or is it B17 now? So question is, if there is a deficiency in the level of that vitamin, using natural remedy now, because I also believe that your food is your medicine, what are the likely sources of this vitamin D17 or B17, as it were, in order to prevent or cure cancer, as it were? So that's my question, please. Thank you.
Okay, so did you say you read this somewhere?
Hello.
Hello, did you say you read this finding from somewhere?
Did you get the question, please?
Yeah, I said the question you just asked, did you say you read this? I'm not sure about vitamin D17.
Yeah, yes, deficiency of vitamin, I think D17 or B17. I'm not sure
Buckman,
which
do you
of
know
it.
vitamin E17? I haven't heard of vitamin E. Yeah,
I read a report some time ago. Yeah.
If you can find, because unfortunately it's kind of hard for me to respond to this one, but I know that like deficiency in vitamin D, I mean, it makes
Doctor, I'm sorry, it's B17. I've read about it, and I think it's in.
Or is it D17 or E17?
B.
Is
B
it D?
as Bravo.
Yeah.
No, B as Bravo.
And
okay, fine.
Where did you read this from, Rose? Where? Which article?
It's on it's a verywellhealth.com
What.com?
Verywellhealth.com.
Okay. So this might be one of those sites out there. Just so I'm not familiar with this.
Yeah, it's an apricot seed. So now they're saying that they're trying to take that vitamin B17 out of the market so people don't depend on that.
Okay, good. See what I'm talking about. So I will have to read more into this because just so you know, so there are websites out there which report stuff because now people tend to the internet, because maybe before I cite a website, I must have done a validation of that site. I don't just use stuff from any site. So
it's also on webmed.com.
Web what?
Med.com.
Okay. Yeah, I'll have to look more into that. But generally, I will answer this question generally. Deficiency in any kind of vitamin is just the body. So when your body itself is not feeling well, it's lacking some things, that's when your body cells can act up. Let me put it that way. And decide to grow anyhow that it wants to grow. So then that may make sense. But I cannot answer in respect to, its impact on cancer per se. So hopefully I've answered your question.
Okay, thank you, Doc.
You're welcome. Okay. Stages of breast cancer. There is stage 1, when there is no lymph node involvement, which that would be good to have. Stage 2, there is some lymph node involvement under the arm or to the sides. And stage 3, as you can see, is locally advanced. There is some lymph node involvement and the tissue near the breast. So stage 3, you can see is so confined to the breast, even though it's gone to some lymph nodes and the tissues within that breast. So stage 4, which is what we looked at in the previous slide, is the metastatic disease, where it's gone outside the breast to distant areas. And we are here at that survival rate of 22%. But the thing for us is people are still living, because I go to these meetings, like I say, and I see people living for years at stage 4 because of the new treatments that we have here. So that
Dr. Koduah, sorry to interrupt. I'm sorry to interrupt. I've just been alerted that we have just about 10 minutes. About 10 minutes.
Okay.
About 10 minutes.
I think we're about done. It's the questions. I just want to make sure I leave everybody happy. So that's usually my goal when I do presentations. And I think we are there. So that's that. Treatment, we've talked a lot about treatment. Remember, I had mentioned aromatase inhibitor. So these are some of the drugs: Arimidex, Aromacin, Femera. They fall under that class for postmenopausal women who are HER2 positive to take, or people who are resistant to tamoxifen. And tamoxifen can be used for both men and women, even when the disease is advanced, for as long as it continues to work. These two drugs, I don't know if you see it in Ghana, Dr. Buckman, Ibrance and Kisqali. I know there are new ones out there. Are you using Ibrance and Kisqali in Ghana?
I'm not sure.
No, probably not. Yeah. So like I said, we have a lot. That's why even though our survival rate is 22%, people are still really living longer, because if this doesn't work next month, you see a new drug come up and the oncologist will put them on. So these are two of the drugs approved also for HER2 negative. So our triple negative women who usually have kind of bad prognosis, here in the US, we use Ibrance and Kisqali. And it's working well. I know there are new ones out there. I think I have a meeting next week. They're going to talk about some new stuff. I can't keep up with it. Side effects from treatment: nausea, vomiting, neutropenia. Neutropenia is when one's white count, or WBC, if you see it on your lab, when that is low, it's in practice, usually when the white count or the absolute neutrophil count, please forgive me, I'm still trying to break it down for you. So, you know, and I know we all get it. Absolute neutrophil count is the matured white blood cell, because that's what you want to have. If that is below 1,000, then the patient is considered to be neutropenia. So when somebody have that, you don't want sick people around them. They cannot eat fresh fruits and veggies. They cannot be in the garden, you know, things like that. Thrombocytopenia, that's if platelet is what helps us so we do not bleed when we get a cut. So if that is below the norm, which is like 150, normal platelet is like 150 to 400. If that low, then that person will be at risk for bleeding. So you teach them, or if that's your family, you help them to not be cutting stuff in the kitchen. I'm saying this so we can all learn how we can help our friends and family. Loss of hair, that happens. Neuropathy, I already talked about that with Taxol and Taxotere. It's quite unfortunate, and I see this in practice. One of the drugs, or a drug class that we use to treat breast cancer, remember I talked about ACT, the A, which is adriamycin, which is idarubicin, and there's daunorubicin. There are different different drugs that fall under this class of anthracyclines. Unfortunately, some patients later develop leukemia, which is another cancer by itself. And definitely when they do have mastectomy, lymphedema, which can be very uncomfortable and needs to be managed. So help your family when they're going through treatment, to help support them with the side effects that come with chemo, because it is not fun. Lymphedema can be very uncomfortable. There are sleeves there that you can purchase for your loved ones, so they can put on that arm to help the reduction of the swelling in the arm. Because what happens is they take out the lymph nodes, so the drainage, there's no place for it to drain to, so it builds up and the hand swells. So then it becomes uncomfortable and it swells, and that is not fun. So those are side effects from the treatment. Survivorship. I think I talked about, let's stop that African style of living, because I think all of us on here are pretty much Africans. Tell your friend, tell your family, you are not alone. Join a group, find that common person that you can talk to, follow up with the oncologist. as established, because sometimes the doctor sets up appointment for us, but we don't go. Even after people have been diagnosed and going through treatment, they just don't show up. Pain management, metastatic disease can be very painful. So cancer pain is very deep. Not that any pain is easy to watch, but when you are watching somebody with cancer pain, it's horrible. It's horrible, it's horrible. So support them.
There's this medication in Nigeria. It is called Every Woman.
Every Woman?
Yeah, almost every woman wants to use it. I don't know. Can you just tell me more about the medication? Let's just have idea of what the medication is expected to do for women.
What medicine is that you said?
Every woman.
Every Woman.
Yes, ma'am.
And it's in Nigeria. I have to Google that. Every Woman medicine.
Is it a vitamin?
I don't know.
Yeah, because those woman stuff, usually in Ghana we have Well Woman, we have
so that's a multivitamin.
Yes. There is another way for the medication. That's another name for the medication, Well Woman.
I think it's a multivitamin, it looks like.
Okay.
It's a multivitamin, which, I mean, I think that's okay, especially if you are, those of us here working, and at some point you need a little booster. So taking a multivitamin does not hurt.
Okay.
I just don't like pills, so I do gummies.
Thank you, Doc. I think we'll take the very last question from Margaret Chichi. Please go ahead.
Good evening. Thank you very much for this elaborate session on breast cancer, Dr. Susan. I really appreciate it. I've really learned a lot. I just want to add to what Grace Buckman had said earlier regarding the situations in countries. For us in Nigeria, we also have some similarities with Ghana, what obtains in Ghana in terms of treatment and diagnosis. A lot of people here pay out of pocket and treatment is quite expensive. Cancer patients have to seek support from family, friends, and sometimes when it's available, they get from NGOs that offer some level of free treatment. And they are not really much when compared to the number of cases we have here. So a lot of advocacy is still ongoing here to get the government to design healthcare programs that can help to reduce the cost of care and also support to cancer patients. Even beyond the care, patient support is very key to their recovery as well. So a lot is still ongoing, and we pray that as we keep making noise about it, government will be able to do something when it comes to financing cancer care in Nigeria. Thank you very much. It's been a wonderful session today.
That's awesome. Thank you for sharing that. Like I already said, we all have a role to play. Let's support each other. There is no such thing as small money. Okay, so if you know of, I believe in these things, just whatever, $5, $10, you never know. If we have 100 people giving $5 to support a mission, see how better the world will be and the lives that will save. I mean, most of the time, when it comes to cancer stuff like this, I usually kind of do it out of my own pocket because it's close to me. That's not tied to my foundation because I have my own foundation supporting underprivileged young girls. That's different. But with cancer, because it's very dear to my heart, which is why I'll be doing what I'll be doing next month. So I will use that to say, if you want to support, that's sort of my way of celebrating myself, because I don't like people giving me stuff for me, I just want to give it out. So to go celebrate with the cancer patients, what the Lord has done. So that is that. I think there is one hand up.
Yeah, hello.
Yeah, please go ahead.
Okay, so actually got a quick question for my wife. So, if you've ever had a breast lump that has actually been removed, a cancerous lump that has been removed, is there any possibility that it can grow back again?
Yes, it can. Which is why I was saying I'm not sure the details of what you said you're asking on behalf of your wife, the details of it. I usually tell people, if you can, just take it off. Do mastectomy, not lumpectomy. So it can, yes. Mastectomy, can it still come back? Yes, but not as quickly. It's just, that my thing is, you do what you have to do and you leave the rest up to God. But lumpectomy can quickly come back, depending on the type of breast cancer. Remember, we talked about like 4 types. Yes. So
thank you very much, Doc. I think we really have to end now. And as Doc has put in her number, those of us who want to direct small questions to her, we can do that after this. As I said, this has really been a wonderful session. And for all those of us on this call, I think knowledge is not enough. Just knowing what breast cancer is not enough. We need to go to the next step of making sure that we do our breast self-exam. And those of us who need yearly mammograms, let's make sure we get it done as well. So thank you all very much. At this point, I will hand over to Caroline to take over. Before that, we can give Doc a resounding round of applause. That was
Thank you, Dr. Buckman, too. Thank you, too.
Thank you for giving me your ears.
Powerful.
Dr. Buckman, thank you, too, for moderating for us. Thank you so much.
Thank you.
Thank you, everyone. It's good to see you after a month. Thank you, Dr. Susan, for taking us through a very important topic to us, to everybody. Thank you, Dr. Grace Buckman, for moderating. Thank you, our President, Bortsie, for organizing this event. And most importantly, thank you to the participants. Without you, we wouldn't have this event. We thank you for registering with us. We thank you for joining us. We thank you for the questions. Thank you for making the session so lively. And most importantly, thank you to Dr. Jacobs and Jagils Institute for providing us with this platform to learn as alumni. And before I invite Dr. Jacobs to give the final remarks, I would like to share with you the announcements. So as you notice, this month we've been focusing on breast cancer, but also we recognize the presence of men in our lives. And so next month, we're going to be discussing about erectile dysfunction.
Oh, wow.
Francis, pay attention.
I am shy doctor.
I believe this is a very relevant topic that we ought to also address.
Caroline, that's a heavy one.
So we would like to address this topic next month. It's a very crucial topic for everybody, for also if you know anyone, your friends, your family members, we are here to learn. We never stop learning. And so you're welcome to the session November next month. We're going to share with you the details on how to register for the function, how to get to just be on this platform, and we'll keep you posted. We look forward to seeing numbers, and also invite your family members, invite your friends, invite your colleagues. We are here to learn all together. And then the other important announcement is that we expect to have our ND alumni virtual party, which I will invite. We will also announce how it's going to be, how we're going to celebrate and end strong. You know, we start strong, but also we should finish strong. So we would want to do that together as a team and as a family. And at this point, I would like to invite Dr. Jacobs to do the final wrap-up of the session. Thank you very much, everyone.
Oh, thank you so much. Thank you so much, Caroline, all the way in the Netherlands. We are so grateful for your time. I just want to take the opportunity to thank Dr. Susan again for such a powerful presentation. For me, if I didn't take anything home at all, I know my wife has no excuse. I need to help her massage her breast, and so I think. But on a more serious note, I think the delivery was so powerful, and all of you could agree with me that I have friends and other doctors who join, and each one of them is sending me sidebar messages to say that who is this lady? She's just so powerful, and so I just told them that, well, in November 13th, she will be receiving a prestigious award, and so they should come and see her as we celebrate her work. She's a selfless woman, and like she said, next month she's going around to help people with cancer. So please, if you can support in any shape or form. It's always blessed to give than to receive, as I have taught this class. Always give and give without anything in expectation as a return. God is a wonder reward. So once again, we are very grateful. Thank you, Dr. Buckman. I know you are very busy. You also left your practice this afternoon to be with us. We are so grateful for joining us. And of course, I want to thank every one of you, known and unknown, those who are members of the Jacobs-Abbey Global Institute, alumni, associates, and friends. We look forward to having you next month as we talk about erectile dysfunction. It's a very important topic because we recently got to know that you can have all manner of wealth. If you don't make your wife happy, all your money and your wealth is meaningless. And so we are hoping and praying that it goes well next month. And so on that note, I think I have exhausted all the information. Those of you who will be able to join us at the award ceremony at the Hilton in Alexandria, we look forward to welcome all of you. And we look forward to celebrate the lives of people who have dedicated themselves to help other people. So on that note, I hand over to Amma Batil, our alumni president, to wrap it up for us. Amma.
Okay, thank you, Doctor. There's not much more to say, but just to reiterate, thank you to everyone so much for gracing this occasion. It is important, like Dr. Buckman said, let's take this information, not just to have it in our pockets, but to actually take action on it. If you know, and let's ask questions about our family history and all of that. We found out, having kids after 35, it's important for us to kind of start this and not wait till 40 when it could be too late. So please, please, please let us do that. And for the men, let your sisters know, let your wives know, let your, moms know, whatever it is, so that we can all take action to prevent this from happening and killing us. We don't need to die if we don't need to, because it's preventable. So on that note, I would like to say again, thank you to everyone for coming, and I will see everyone next month, God willing. Bye.
Bye.
Bye. Thank you. Thank you. Bye-bye.
That's so nice seeing your face again.
Bye.
Bye-bye, everybody.
Bye.